Thanks, Kathy. And I will say, in response to my friend Alan Leshner, that one of the best things I ever did for the field was recruiting him to be director of NIDA many, many years ago. So thank you. And I feel comfortable trying to set the stage from kind of a historical perspective, because I pretty much lived through this problem for many, many years. I really have no financial conflicts in this regard. And I thought I'd just mention just very briefly the fact that we've had opioids for 3,400 years BC, actually. The Mesopotamians called it the joy plant, and indeed they found that it's the best treatment for pain that we have. It's really a good drug, and we don't want to just call it something bad, because this does a lot of really good for the world, and it has for thousands of years. I'll skip forward to things that are really relevant to this problem that we have now, in that in 1843, morphine given by a needle and syringe was invented. This was important for Civil War injuries and pain for Civil War veterans. In 1874, after opium was being kind of a problem developing, heroin was synthesized, and the name heroin comes from hero, because it was a drug used to treat opium addiction. And by the early 20th century, we had huge numbers of people who were dependent on opioids in patent medicines and in pain medication. And the historian David Musto, studying the literature of the day, concluded that the prevalence of opioid dependence in early 20th century was higher than it is today. So that, that's really a fact about the power of this drug. Congress reacted in 1914 to pass the Harrison Narcotic Act, which clamped down on this, closed all the heroin clinics. Yes, we had heroin clinics in those days. Doctors were treating opioid addiction, and it became illegal for them to do that, and to this day, actually, except for the waivers for buprenorphine. And doctors actually went to prison for continuing to treat patients, so that it was a very serious issue. And over the next decades, the only places in the country where opioid addiction was treated was at the narcotic farm, so-called, in Lexington and Fort Worth. Lexington developed really an early form of the NIH and then the forerunner of NIDA. And they did some great research in its day, although there was some conflicts that Senator Kennedy discovered in terms of giving opioids to inmates there for studies. But this is where the whole concept of multiple opioid receptors was developed through the intuition of the pharmacologist Bill Martin as mu, kappa, delta, and sigma opioid receptors. This had worldwide impact, and it led to a philosophy for medicine of very, very restricted prescribing of opioids. And people began to criticize this, looking at the treatment of terminal cancer patients and finding that 40 to 60% of them were needlessly suffering because of inadequate opioids. And minorities were 3 times more likely to be undertreated. Women and the elderly were also undertreated. And there was a debate about physician-assisted suicide, because if you gave people more opioids, you might hasten their death. And as a resident myself, I was involved in some discussions and debates about whether we should give someone dying of cancer a little more morphine to make them more comfortable. This was an issue. My own reading, especially as someone who's chaired the DSM committees on addiction several times, that there was a confusion between dependence and addiction, and I'll talk more about this, but it had to do with a confusion that when someone is dependent, this is normal. This is not necessarily anything wrong. This is not an addiction. Addiction involves compulsive, drug-seeking behavior. And so there was a force that developed to consider pain as the fifth vital sign and to make sure that everybody was adequately treated. And unfortunately, it began to spill over into the non-cancer area. I'll just mention one patient example that to me is still very striking, and that is Dr. Albert Sabin, who was the discoverer of the oral polio vaccine. And it happened that I stayed up late one night when they were talking about polio on Nightline with Ted Koppel, and he found Dr. Sabin at the NIH Clinical Center dying of cancer, and they thought they would get him to talk about his discovery of polio treatment, and instead Dr. Sabin couldn't talk about anything except his pain. He was obviously suffering, and he kept saying, "My doctors don't trust me. They won't give me enough morphine. I can't even talk about anything but my pain." And that to me was a terrible thing showing up on live TV. But it's an example of how we undertreated pain. So, you know, there was a reaction to that developed soon afterwards in the 1990s and early teens, in which people were pointing out the fact that opioids were very benign in many ways, because they didn't have any organ pathology, whereas the non-opioid medications cause liver damage, kidney damage, bleeding of the gut. I already mentioned the ethical questions that came up of treating pain. So one of the issues that I think has led to these problems is the failure of people to distinguish between dependence and addiction. And tolerance is partly enzymatic and partly conditioned. Pavlovian condition is involved. There's a whole literature on conditioned tolerance. We've demonstrated in our lab very clearly that a signaled opioid dose gives much less effect than an unsignaled one when the body is unexpecting it and doesn't have the conditioned adaptation. Withdrawal occurs when you stop or decrease any drug in a number of categories, and it may continue for days, weeks, or even months. And that was one of the contributions of the NIDA Addiction Research Center. And how you treat withdrawal. Tom McClellan did a review of medical school's curriculum in 2012, and only 8% of medical schools in the United States had a course on addiction, and 36% said they covered the material. But you know, this was clearly inadequate. Other drugs that produce dependence are things like antihypertensives, antidepressants, anti-anxiety medications. And so we need to understand this in order to properly treat pain. The current definition of a substance use disorder comes from DSM-5, and one of the big changes was adding craving, and I'm glad people were talking about craving earlier this morning. We know a lot about the neuroscience of craving, which I'll mention later, but these latter things about craving, using more than intended, unsuccessful efforts to cut down, these are all parts of the substance use disorder diagnosis. As we learn more about the underlying brain changes, we're able to make the diagnosis in a more objective way. We teach our students, at Penn we've had a course on addiction as an elective since 1971, and it was a required course beginning in 1989. And we teach them that when you prescribe opiates, you should have a specific diagnosis, a goal, a limited time if it's post-surgery. If it's terminal illness, your goal is comfort for the patient. Avoid prescribing opioids in chronic nonspecific pain. And on people on chronic pain, on chronic opioids, have a very difficult time getting off of them. And this is one of the difficulties we have. And I think that your committee will have to address this, because most people, when they want to start on methadone or buprenorphine or any other agonist, they don't really think of it in terms of lifetime. I started the methadone program at the Philadelphia VA in 1971, and we've treated thousands of patients, but very few have been able to make it off of the medication and become abstinent. Very few formal studies have been done, and I know Dr. Volkov mentioned the long-term studies. We need more of that. But in the 1970s, Barry Stimmel did a study in which he started with people who had been on opiate for a year or more, had clean urines, wanted to stop, and then stopped gradually, and then followed them up a year later, and 85% of them were already either back on heroin or back on methadone somewhere else. It's because it's really difficult to stop an agonist once you've been on it for a long time. We need to teach the students about the variations in the different forms of opioids, those that are short-acting, long-acting, immediate release, that have non-opioid effects like meperidine that's been taken off the pharmacy in many places because of its significant non-opioid effects. But if a doctor is going to prescribe opioids, they should know all about the half-life and the characteristics of the medications that they're prescribing. And this has led to problems. Methadone turns out to be a very good pain medication, but you have to understand that it has a very long half-life, and too many, and as a matter of fact, I've been invited as an expert in some of these tragedies where somebody was given methadone and they took it at bedtime and never woke up, because it's a way that you can prescribe it, but you have to do it carefully. In the beginning of the 1990s, people started recommending opiates for non-malignant pain, and I think this was ill-advised. I disagreed with this, but because I saw so many examples about people on opioids for non-malignant pain, and I'll just mention that in some cases they developed what we call a parallel epidemic, where they would go to the street when they couldn't get enough opioids from their doctor. This varies. Wilson Compton did a really excellent review in the New England Journal recently, but he concluded that the switch to heroin was relatively small, but I think it varies according to the city. The availability of fentanyl is a relatively recent problem, and this drug is very, very dangerous, and it's hard to reverse the effects even with naloxone. I think this is why Philadelphia is proposing safe injection sites as they do in Vancouver, for example. I'm in favor of that, even though I'd rather get more people in treatment. We could probably discuss that later. But this is one of the controversies out there right now. To save lives, do you allow people to inject in sites where you have medical personnel to save them if they need it? This list of diagnoses here is from my practice. When I got out of the Navy, I think I was one of the few people in Philadelphia who felt comfortable treating addiction. And so in addition to my VA job, I had a private practice, and people referred, you had no problem getting patients because nobody wants to treat them. And these were some of the non-malignant diagnoses that I treated. Most of these patients in this list were MDs, physicians who had gotten themselves addicted. One was a pharmacology graduate student. So I had some smart patients who taught me a lot about addiction, but I also had to treat their pain. And I put most of them on methadone, which would have been illegal according to the Harrison Narcotic Act if I were treating them for addiction. I was treating them for pain and addiction, so I could give them a prescription and they could take it to a pharmacy. As long as I put pain on there, that was legal. If I didn't put pain on there, I would have to put them in my methadone program, which is like a drug bazaar because, you know, we had as many as 600 patients on it. In New York, they have thousands in some place, and people go there to sell drugs. I treated them in my private office, and they were good patients. You know, they worked with me. But I did find, just as one little tip, was that I had the impression that tolerance to methadone developed less rapidly than to other opioids, and that's why it remained a good medicine for pain in these patients, and it might be because of its effects on the NMDA system, but for some reason it was very useful to me to use methadone as a pain medication. I want to just make the point that there's a lot more to treating pain than with medication. Someone mentioned family therapy. I think that's the most powerful form of talk therapy that you can imagine. But when we teach students how to treat pain, we include good cognitive behavioral therapy, non-opiate medications, use of caffeine as an adjuvant. These drugs can be dangerous, but they're non-opioids, and you know, and I don't have time to go into the details. But you know, it is possible to treat pain without putting patients at risk of addiction. The tolerance issue, I think, is really a serious one, and there's been a lot of debate in the literature about the usefulness of opioids chronically. It turns out, if you look at the literature, the longest studies for chronic opioids are 7 months. Recently, my colleague Marty Cheadle and I tried to do a 2-year study where we had control of the pharmacies and the patients were being treated by primary care docs or internists for back pain. So this is dangerous, but these physicians were so well trained that they didn't let the drug, the dose get up very high. It did relieve the back pain, but we couldn't continue the study for longer than 6 to 12 months because so many of these patients, and they had been selected for, you know, they weren't people who seemed to have a genetic propensity for addiction, which is another issue in itself. But they by 6 months, most of them wanted to stop the opiate, which is fine. I mean, I don't recommend giving opioids for back pain, but it's done every day. And if you're going to do it, then you better select your patients carefully and screen out those who use marijuana, who are smokers and have DUIs and things like that. Anyway, I'm going to skip this because I'm running out of time, but there's lots of other non-medication strategies. There's things that we can do. I want to talk about the fact that we have very good addiction neuroscience, largely because we have valid, predictive animal models. We've learned about the role of the reward system and lots of evidence about conditioned craving, conditioned dopamine release. We have all kinds of we have several different kinds of anti-relapse medications. And we have developed some new meds through translational research. Unfortunately, most patients are still treated by residential programs, which are very expensive and have as far as I know, there's no evidence base for them. I'm very much in favor of the 12-step model, but not as a treatment by itself. And unfortunately, so many patients, so many families get trapped in the residential program system where they don't use medication, and the patients relapse and overdose. And I get called by people who said, why didn't anyone tell me about medications? I mean, this is something that I hope the efforts of your committee can improve on, but so many people are prevented from getting medications. So we do have FDA medications. You already talked about that. The best news I heard this morning so far is that SAMHSA is trying to get the buprenorphine waivers into the curriculum for medical school. That's very good, and I applaud that. The final point that I want to make, and I hope I'll get a chance to talk about it more, is the fact that we have a medication called naltrexone. It's an antagonist. It truly blocks the opiate receptor. You'll see articles talking about a blocking dose of methadone or buprenorphine. That's a bad way to talk, because there is no blockage. Agonists activate the receptor. Naltrexone blocks the receptor, and it produces a ability of the patient to learn to live without getting high every day, and to stop taking a medication and become abstinent without going into withdrawal. I wish I had more to talk about it, but I want you to know that it's easy to start agonists, just like switching them to another brand of heroin, but it's very hard to stop them. And in all the years that I've been using methadone in my program, very few have ever been able to successfully stop it and stay in a stable, abstinent state. Thank you very much.
Thank you very much, Dr. O'Brien. That was wonderful, and there's plenty more to talk about, but we do want to move on to the other speakers.